So in that paper, we looked at 3 groups of patients, and we chose these 3 groups based on the intensity of therapy. So the least intensive therapy is a doublet of hypomethylating agent and venetoclax, and then you get this kind of intermediate kind of intensity, which is cladribine, low-dose cytarabine, and venetoclax. And then we have the most intensive, which is intensive chemotherapy and venetoclax, and that was people who got either FLAG-IDA-VEN or CLIA-VEN. And then we looked only at the NPM1 positive people, which I think were about 20% of the overall cohort, about 100 patients, if memory serves me. And we looked at how they relapsed. And so just as a background to this, the proportion of NPM1 patients who relapse without NPM1 with just intensive chemotherapy without venetoclax is about 5 to 10%. And so we were quite surprised when we looked at our cohort. The rates of NPM1 wild-type relapse were really about 40 to 60%. And so I think, and also one of the other things that we noted was that the more intense the treatment, the higher the rate of NPM1 wild-type relapse. We also looked specifically at these relapses. They have a longer lead time to relapse than the NPM1-mutated relapses. And we looked at the immunophenotype by flow cytometry, and they appear to be different leukemias. So it looks like the venetoclax-based therapies are effectively curing these NPM1-mutated leukemias, and that the relapses are either a different clone that was present at the low level at diagnosis, or possibly a secondary type AML.